My name is Karen Lambert, and I invite you to join us for this FPMA Young Member Seminar Series. It's the fifth in the series. It's titled ICD-10 CPT Cracking the Code. This is a non-CECH event. Our next in the series will be held September 13th. It is sponsored by BACO and will feature Dr. Lily Kavari. Tonight, our featured speaker is Dr. John Goggin. Dr. Goggin practices in Fort Pierce and is FPMA's immediate past president. Without delay, I give you Dr. Goggin.
Thanks everybody for attending this. I hope it's informative. Unfortunately, it won't be very entertaining. I will try to go through this, and if there's time at the end for questions, I'll try to take some questions as well. So this presentation is designed to be a very basic primer on medical coding. It's not really a practice management lecture. It's not telling you the ways to code a procedure correctly, what have you. It's more the nuts and bolts of how coding works. It's what you need to know before you can really do any medical billing. And even if you don't do your own billing, it hopefully be helpful in communicating with your billing people. So for some people who are more seasoned practitioners who've been doing this for a while, unfortunately, this may be a little lower level than you're accustomed to, but hopefully it's informative. So first, we look at why do we need the complex medical coding system that we have? And the answer is fairly straightforward. There's essentially 5 billion medical claims per year filed in the United States between private and public insurance companies. So in order for that to work at all, we need to have some sort of a standardized coding language that we can all use and understand. So it's just essential that we have these types of systems. So when we talk about medical coding at the professional level, the physician level, we have CPT, which is our current procedure terminology. This is a list of procedures that's maintained by the American Medical Association. When a new procedure becomes established, there's a long and complex process for that procedure to get a CPT code. And until there is one, it becomes very difficult to build some of these new procedures. The next thing we look at are the International Classification of Diseases, the 10th revision. These are our diagnosis codes. So we have our procedure codes, and then we have our diagnosis codes. And then the final that we'll just briefly touch on are our HCPCS level 2 codes. And these are for drugs, biologic supplies, medical dressings, orthotics, prosthetics, durable medical equipment, things of this nature. So we'll start with CPT. So all CPT codes have 5 characters. The majority of the codes are numeric, and I've listed a couple of common podiatry codes here. And you can see that, they're all 5-digit numbers, pretty straightforward there. You will, at some point, if you do your own billing, get so that you have memorized probably anywhere from a couple dozen to a couple hundred of these codes just by repetition. But essentially, there are books published that have these codes all listed and indexed. There are computer programs that do it. There's a whole bunch of different ways to look these up. Historically, it's always been with books that are published at the beginning of the year. APMA has a great resource that is the Coding Resource Center, where APMA members can subscribe and get a very concise version that's kind of pared down to be foot and ankle specific. At any rate, occasionally you'll find a CPT code that has a letter at the end. These are usually for provisional procedures, so procedures that CPT isn't sure is going to be something that they're going to ultimately assign a valid procedure number to. And here's two that might be used in the podiatry world. Again, we don't see these very often. These are codes. They're sometimes referred to as HCPCS level 1's codes as well. Not really important, but you sometimes will see that terminology. So when we're talking about CPT, you can kind of break CPT down into 6 subcategories, so to speak. Evaluation and management, anesthesia, surgery, radiology, pathology and lab, and medicine. And I've highlighted the 3 that we will be kind of most likely to be using in most of our podiatry practices. So other than our procedures, then we have our diagnoses. Currently, we use International Classification of Disease 10th Revision, or ICD-10. This replaced ICD-9 in 2014 in the United States. And just for perspective, 1993, the rest of the world went to ICD-10. I believe most of the world is currently on ICD-12, and ICD-14 is actually in development. So something to look forward to. ICD-10 is 3 to 7 digits long. The first digit is always a letter, and it'll tell you what chapter of the ICD-10 book, so to speak, it is in. Again, most people are using computers to look these up, but it's still broken down that way. Digits 2 and 3 are always numbers, and then 4 through 7 can be letters or numbers. And this is just kind of a quick look at the various chapters. So I've highlighted in red the chapters that we as podiatrists often will find diagnoses that we work with located in. So if you were looking for one that I know off the top of my head, tinea pedis is B35.1, I think. And so it's in this chapter B, certain infectious and parasitic diseases, neoplasms. This is where you're going to find your squamous cell skin cancers, what have you. Your neuroma is going to be here, and diseases of the nervous system, and so on and so forth. And again, if you can think of a disease or condition, you would expect that there would be a CPT code for it, but there's a couple of exceptions that there aren't. So this is an example of a actual CPT code, just to kind of demonstrate how much depth there is to the ICD-10. So this is a V code, which indicates that it is external causes of morbidity and mortality. So V97.33XT, sucked into jet, subsequent encounter. So again, there's a code for everything. And I'll throw some of these more humorous codes in through here to kind of break up some of this lecture a little. So the last thing that we're going to touch on are the level 2 codes, or HCPCS level 2 codes. And this is basically the catch-all for everything that doesn't fall into the procedures or diagnosis codes. Things such as ambulance services, oxygen, ostomy supplies. The thing that we're going to be most interested in is going to be the durable medical equipment, prosthetics, orthotics, and supplies. All of these codes are a single letter followed by 4 numbers. So again, the durable medical equipment, prosthetics, and orthotics is something that many podiatrists will choose to use in their practice. If you're in private practice, this can provide both the convenience for your patients. You can assure that they're getting the device that you want them to, and fairly quickly. Picture of a cam walker here, fairly classic. It's, you know, a great inconvenience when you run into somebody who, because of their insurance or what have you, you have to write them a prescription for the cam walker that they really should be walking out of your office in. and they're getting it 4 or 5 days later. So it's nice if you can do your own dispensing. It does require separate registration with Medicare to get a durable medical equipment number. There are very strict and complex rules. The application process is a little bit draconian, but it definitely is worthwhile to do if you're in a private office setting, just to be able to have the convenience of giving your patients things they need, and it can generate some revenue as well. So as you'll kind of see as we go through this, that medical coding can be quite daunting, but we'll try to use some examples and see if we can clarify some of what some of this stuff is. So for CPT or our procedures, I'm going to spend probably an inordinate amount of time talking about evaluation and management for a couple of reasons. A lot of what we do is evaluation and management. These are our office visit codes. And in addition to that, there was a recent change to this in 2021. So even some people who have been practicing for a while still are just wrapping their heads around how this new system of using these codes works. And in addition, this is a lot more complicated to figure out which code to use than your procedure codes. You know, you do a bunionectomy, it's pretty easy to look at the 4 or 5 available codes and match the code to the procedure you actually did, but this becomes a little more complex. So 99202 is the code that we use for a initial outpatient or office visit. It requires a medically appropriate history and physical exam. It used to be that we had very specific points. You had to have 6 things in your review of systems and 2 points for your HPI and 6 systems examined and so on and so forth to figure out what code to use. That's been all replaced with a system that uses just medical decision making or time, and you don't mix and mingle these. It's one or the other. So if you have a patient who requires straightforward medical decision making, that's going to be a level 2 visit, and we'll talk about what straightforward is, because that becomes important. If you're using time, 15 to 29 minutes is the typical time for a level 2 new patient visit. Should be noted that if you're using time, it's the time that is on the date of the encounter. So for instance, if you had a patient who came into the office and you reviewed some notes from the primary care physician before you saw the patient, you looked over some tests that the patient brought with them, and you wrote your note, and you did it all on the same day, you could add up the time you spent on all those tasks. And if it came between 15 and 29 minutes, you have a level 2 visit. However, if you looked at those notes on that patient in anticipation of them coming the next day, or if you did your progress note a day later, you can't count those towards that day's encounter. So try to get your notes done on the day that you did the patient. And when practical, try to review the information the morning that you're going to see them instead of the day before. So same thing for a level 3 visit. 99203 for a new patient requires low level of medical decision making. Again, 30 to 44 minutes. This probably is the most common new patient office code for podiatry. The level 2 code gets used some as well. It depends on your patient population, I suppose. Level 4 requires a moderate level of medical decision making. This is a 45 to 59 minute visit. prior to the changes that occurred in 2021, it was fairly unusual to be able to use this code as a podiatrist. However, moderate medical decision-making is a fairly easy threshold for us to reach. So this has become a more relevant code for us. And the level 5 visit, similar. It's a high level of medical decision-making. This is a 60 to 74-minute visit. And that is not going to be so common, but again, high level of medical decision making is certainly something that can be achieved on the right patient. It'd be pretty unusual for an office patient for you to spend over an hour with them, but it could happen if you're coding on time. Again, a little code for everything. So these are the parallel codes for the evaluation and management in the office setting for patients that are established. 99211 is unique in that there is no 99201. So this is what we call a level 1 code, or a very basic code. It's not used very often by podiatrists or specialists in general. It may not even require that the physician be present when the patient is receiving the service. However, you must be in the office. It's something that is more of a primary care code. However, in theory, if a patient came in for a wound check and you were going to have your medical assistant change the dressing, which we are now allowed to do thanks to our recent legislation. Thanks again to everybody on our legislative committee and those who contribute to the FPMA PAC. That would be a situation where if you didn't see the patient, but your medical assistant changed the dressing, you could bill a level 1 visit for that. Level 2 office visit, this is your basic kind of entry level follow-up visit for evaluation and management of the patient with a problem that requires straightforward medical decision making, basically a 10 to 20 minute encounter. And again, just like the level 3 new patient, it requires a low level of medical decision making in 20 to 29 minutes. One thing worth noting, because you don't see the slides all at once, obviously the level 3 visit for a follow-up patient is a much shorter time frame, about half the amount of time, in fact, than a new patient for the same level of service. Level 4, same thing. I know this is getting repetitive. It's a moderate level of decision making, and again, 30 to 39 minutes on the date of the encounter. And level 5 is where we get to the high level medical decision making. And again, we'll talk about what this low, medium, and high is. A 40 to 49 minute encounter. And it should be noted that there are codes that can be added on when there is either additional time or even additional complexity. But those codes are relatively rare to be used. They're more likely to be codes that we use in the critical care arena. It's not impossible that you would use these codes, but it's a little beyond this discussion. Again, there is a ICD-10 code for almost anything. So this is a very busy table, and unfortunately, I'm sorry, it's a little blurry as well. This is a table that's published by the American Medical Association in anticipation of the new coding changes coming out when they changed over to this new system in 2020. And it is all over the internet. You can get it from the American Medical Association's website without being an AMA member. And I highly recommend anybody who's trying to figure out their codes in their office, get a copy of this and set it on your desk. So I'm going to kind of go through this huge chart a little at a time and see if we can make some sense of it. So again, there are 4 levels of medical decision making. There's straightforward, low, moderate, and high. And when we decide what level of medical decision making we're talking about, there are 3 components that determine the complexity of medical decision making. First thing we look at is the number and complexity of the problems being addressed. And again, it's important to remember that this is addressed at that encounter. So you can have a patient who has a lot of medical problems. If they're not relevant to what you're doing, then it really, you don't get to count that towards that number of problems. The amount and complexity of the data to be reviewed or analyzed. Again, the data has to be relevant to what you're doing. And then the risk of complications or morbidity, mortality that's associated with whatever treatment you're going to recommend, or with the condition that the patient presents with. And then this is a horrible sentence, but it's the best way to describe it. So you base the complexity of your medical decision making on the lowest of the 2 highest of the 3 components. And this next slide hopefully will clarify that. So if, for instance, you had a patient who you've calculated to be a level 2 on the number and complexity of problems, a number 2 on the amount of data, and a number 2 on risk, you could drop the lowest and you'd be left with only 2 numbers, and then you'd pick the lowest of the 2. In this case, they're the same. So this is a better example here. You have a 3 for the number of complaints or problems, 5 for complexity of data, and a 2 for risk. You can drop the lowest, you pick the lowest of the 2, and it puts you here, and it follows through this. So as a couple of more concrete examples, let's look at this one here. So this may be a patient who comes in who's medically uncomplicated and has, say, a verruca. So simple problem. There's really no data for you to analyze to speak of, and the risk of them being harmed by whatever treatment you choose, rather it's putting cantharon on it, freezing it, curetting it, whatever you do to them, is fairly low. So it's going to end up being a level 2 visit. The next one, possibly a diabetic patient who really doesn't have a whole lot of complications from the diabetes, comes in, but they have a lot of data to review. They have some nerve conduction studies for you to look at. They have some hemoglobin A1C and some Chem7. So you review all that data and it gets you up to level 5 there. But because there really isn't much going on, you find that there's really not a whole lot of complexity or risks associated with you're essentially counseling them on keeping their blood sugar under good control and so on and so forth. So you get to drop the lowest, you're left with a 3 or 5, and you're going to pick the lower of those 2. So when we're determining the number and complexity of the problems, for a level 1 established patient visit, this is basically like a nurse visit like we talked about. You don't need to have anything wrong with you even. For a level 2 code, which again is where things usually kind of start, somebody with a self-limited or minor problem. So it's something that's going to take care of itself, whether you treat it or not. More often than not, the patient may not know that. The classic example that's given often is a bad sunburn. For us, it could be a sunburn on the top of somebody's feet or something like that, or something that's, going to take care of itself, but they may not know that. Level 3, is going to be low complexity. And this may be 2 or more self-limiting minor problems. So somebody who maybe has plantar fasciitis and onychomycosis. would be a kind of common somebody walks into your office type example of that. Or a stable chronic illness. So maybe somebody who has diabetic peripheral neuropathy that you've been seeing for a while and it hasn't really changed. Or an acute and uncomplicated illness or injury. Again, this may be something like a simple ankle sprain or something to that effect. Level 4, you have a lot more choices here. Again, one or more chronic illness with an exacerbation, progression, or side effect of treatment. So an example here might be somebody who has diabetes that is has neuropathy that's been getting worse. You've been following them for a while and you see that they're getting worsening neuropathy. That might be an example, or worsening peripheral arterial disease. 2 or more chronic stable illnesses might be a patient you're seeing for at-risk diabetic foot care that has severe PAD and diabetic neuropathy. An undiagnosed new problem with an uncertain prognosis. A diabetic foot ulcer would be a good example here. An unstable ankle fracture, maybe in a higher risk patient. An acute illness with systemic symptoms. So cellulitis would be a good example of this. An acute and complicated injury, again, like an unstable ankle fracture, calcaneal fracture, something of that nature. Level 5, again, 1 or more chronic illness with severe exacerbation, progression, side effects of treatment. This might be, for example, a diabetic foot infection that you're going to put in the hospital. An acute or chronic illness that poses threat to life or bodily function. This might be a compartment syndrome, again, a deep space infection, any ER to OR type thing that we might encounter would certainly fall into that category. Again, another ICD-10 code. So the next thing we look at when we're determining our level of medical decision making is the amount and complexity of the data to be reviewed. And again, for a level 2 code, you essentially don't need anything. You don't need any x-rays, labs, what have you, in order to reach the threshold for level 2. So level 3 is going to be a limited amount of data, and you need to have either meet category 1 or category 2. So category 1 is going to be any combination of 2 of the following. So review of external notes from a unique source. So if you had a primary care doctor's note and their endocrinologist note, and you felt that it was relevant to the visit, that you reviewed those 2 notes and you read them and reviewed them, that would count, because that would be 2 unique sources. Or if you had a note from their primary care doctor and you had a CBC or a culture, again, those 2 would come together to be to meet these combination criteria. Common question related to this is, for the most part, although it's not really spelled out, most people I think agree that you can't unbundle your CBC and say that the hemoglobin's one test, the hematocrit's another, the red blood cells another, white blood cells another. Basically, your CBC's one, your Chem7's one, and then any a la carte test, like if you order uric acid, that would be a unique test that's, you know, separately ordered. But things that are routinely done together, you kind of bundle those together. And then assessment requiring independent historian. This is kind of a odd statement, but essentially what this is talking about is if the patient has advanced dementia and you're getting the history from their medical proxy, that would meet this criteria. Similarly, if it was a young child and they were really not able to tell you what was wrong, and you got the history from the parents, or if there was, again, a complex medical history in a child, and you had to get the history from the parent or proxy. That's what this is talking about. So level 4, you have to meet one of these 3 categories. And again, you can't mix and match within these. So you either have to get any combination of 3 of these, or the independent interpretation of a test. So this would be an example. This would be patient comes in from a radiology department and hands you a CD that has a CAT scan on it. And you have to pop that in your computer and look at the images and interpret them. And there's no report provided. Similarly, if there was a report provided, but you disagreed with the findings of that report or found something that was omitted from that report, that would be an independent interpretation as well. And then discussion and management of tests or interpretations. This would be contacting another physician or nurse practitioner, what have you, and discussing the planned management with that physician. So for instance, if you had a patient who came in and had acute gout and you wanted to put them on allopurinol, but weren't certain because of some of the other medicines that they took, you could contact their primary care physician. You two could discuss it, and if it came to the conclusion what you're going to do, that would be a situation where that would count. It's external physician, however, so if that person was in your group, so if you're in a multidisciplinary group and ask your primary care physician partner if they think that something's appropriate or what have you, then that would count. Similarly, if you have a patient who has a calcaneal fracture and you're trying to decide how you're going to fixate it, you want to discuss it with your partner, that doesn't count. And then a level 5 is essentially the same criteria as the level 4, but you need to hit 2 of these categories instead of just 1. And then the final thing that we look at is the risk of complications and morbidity or mortality. For level 2 and level 3, essentially minimal risk. This is going to be something like taking a piece of nail for PAS. You could be doing this in your office and have the electricity go out and it suddenly goes completely dark while you're clipping the nail, and you have a seizure at the same time. You're still not going to hurt that patient. The level 3 is a low risk of morbidity and mortality. This is going to be things like a cortisone injection for plantar fasciitis, a local nerve block, a neuroma injection, things like that, where there is a small risk, but it's very, very low. I think venipuncture is actually used as an example in some of the other literature on this. So for risk level 4 is where it starts to get a little more specific, and it kind of gives you an idea of how low the threshold is here. So prescription drug management. So you give the patient more or less any prescription drug. I kind of interpret it as something that carries some risk with it. Decision regarding minor surgery for a patient that has a risk factor. So if you decide to do a incision drainage of a paronychia on a patient who has peripheral arterial disease or who has poorly controlled diabetes, that would meet this criteria right here. This decision regarding elective major surgery without identifiable risk factors. This is a perfectly healthy patient who you decide you're going to do a total ankle arthroplasty on, or other fairly significant elective procedure, but it's an otherwise pretty healthy patient. And then diagnosis or treatment significantly by social determinants of health. That is kind of a confusing statement, but it's kind of word for word out of that matrix. And that's essentially is where the patient's treatment plan is going to be limited by their ability to participate in their own care. So someone with a diabetic foot ulcer who you tell them that they are unable to be weight bearing on the plantar surface of their foot, yet they work in construction and that's how they get their health insurance, and they essentially aren't going to do what you tell them to do. That's going to fall into that category. Somebody with dementia that's not going to be able to understand some sort of complex dressing regimen that you want to give them, etc. And then level 5, these are your highest risk patients, drugs requiring intensive monitoring for toxicity. Generally speaking, that's not going to be something that we're probably giving most of the time. However, if you do your own antibiotics, there are some that we're going to fall into that category for IV antibiotics, especially in your renal patients. Decision regarding elective surgery in a patient with risk factors. So this might be, you're going to do fix an ankle fracture on a patient with diabetes, or you're going to reconstruct Charcot. They're going to fall into this category. Regarding, emergency major surgery, so somebody comes in with a dislocated ankle, you're going to take them to the OR and put an external fixator on it, what have you. That's going to hit that category. Decision regarding hospitalization. So this is actually, again, level 5 visits were something that were pretty rare in podiatry, and in fact, all but impossible with the old criteria. However, again, decision to hospitalize somebody who has a post-op infection, somebody who has bad diabetic foot infection, what have you. It's not an unusual circumstance for us to put somebody in the hospital. So don't forget we can do level 5 visits. That's something for people who've been out in practice for a while. It's kind of hard for them to remember, because essentially there was a ceiling at 4 and we were afraid to even reach up and touch that ceiling. Decision to de-escalate or stop care due to poor prognosis. That's not typically us, but it happens every once in a while. You're treating somebody with a bad diabetic foot infection and you're the first one to mention the hospice situation to the family. Again, there's an ICD-10 code for everything. So a couple of examples of how this kind of all works. So you had a 36-year-old female with some posterior heel pain. It's been getting worse for the last 3 weeks. Patient has a fairly uncomplicated history with some GERD and peptic ulcer disease, history of an appendectomy. No social history to speak of. Everything's consistent with an Achilles tendonitis without evidence of a rupture. You've got an X-ray. You reviewed an X-ray from an outside source and an ultrasound from an outside source, and then you prescribe a fairly straightforward treatment plan. So patient has this would be an acute, uncomplicated injury or illness, simple Achilles tendonitis. However, you did review a couple of tests from outside sources, so that puts you again in this low category. However, because you gave that patient a non-steroidal and they have a history of GERD and peptic ulcer disease, it'd be fairly easy to say that there is some risk associated with putting them on prescription medication in that situation. So it puts you down here. But when you drop one of these two, you're going to still end up here. So this is a level 3 visit. So look at a little bit more complex situation. You have a 66-year-old patient present with a diabetic foot infection. They have a history of diabetes and kidney disease, high blood pressure, coronary artery disease. They've had a cabbage. So 50-pack-year smoker. And you find that the patient, is basically a sick patient. So you see some subcutaneous emphysema, changes of osteomyelitis. So this is a patient with an abscess and sepsis, and you admit them to the hospital and plan to take them to the operating room. So right off the bat, this is a patient with a severe exacerbation of their chronic disease, that being the diabetes, and or the diabetic foot infection, depending on whether this is the first time they presented with the foot ulcer. You really didn't do any interpretation, any tests. You didn't have any lab work or anything like that at the point that you admitted them. You're going to have a lot of that the next day in the hospital, but hospital coding is different. I did make a little note to myself to kind of point out, we did say back there that you took an x-ray and saw some subcutaneous emphysema. You do not get points for tests that you do yourself. So if you take an x-ray, you have an ultrasound in your office, you do those things, you can't count those tests in the data. Those are separately billed, and they include the interpretation in the billing portion for the test. And that's something that you're going to find debates on, but it's been clarified by CMS that that doesn't count. So if you hear that it does, it's unfortunately is bad advice. Again, might have some patients who need this ICD-10 code. So next, we're going to talk a little bit about modifiers. So modifiers are short codes, 2-digit codes typically, that are appended to the end of your procedure codes to tell the insurance company that you are using two codes that usually are not allowed to be used together, but you have a specific reason for doing so and that you're justified in doing so. And this essentially, when the companies process claims, it's a computer that's doing all of the processing, and these modifiers essentially tell the computer to ignore the fact that it should say no to this combination of codes. And there are a lot of modifiers out there. I'm going to touch on the ones that are really important for us to understand because we use them frequently, and it's important to use them appropriately. You can almost always put a modifier on a combination of codes and get the procedure paid, but the object is to do it right and not just what you get paid for. Just because you got paid doesn't mean you did it right. And insurance companies will come back and take that money back, and Medicare will come back and potentially say you committed fraud. So you want to learn how to use these and use them correctly. So the probably most commonly used modifier is modifier 59. And modifier 59 is a modifier that tells the insurance carrier that I understand that these two codes are typically not supposed to be used on the same patient on the same date of service, but they're not related to each other in any way, shape, or form. And a example of this might be that if you have a patient who presents with an ingrown nail and plantar fasciitis, and you avulse the nail and you inject the heel, there's no way that those two procedures are in any way, shape, or form related to each other. But the insurance carrier may say that they are, so it's appended with a 59. This particular example, you probably would get paid without the 59 because they're probably not in the same bundle, but most people would put a 59 modifier on the second procedure. So a common question that people ask about 59 modifier is in the same example we had last time, is if you took an x-ray, would you need a modifier on the x-ray? And the answer is no, because x-rays are not included in the bundle for either of those procedures. And generally speaking, nothing we do includes the x-ray. So if you have a patient who you did surgery on and they're in a 90-day global period, then you take an x-ray during that period, you're allowed to get paid to take and evaluate that x-ray. It's not part of the procedure. And the same would be true for billing for the Medrol that you injected the neuroma or the heel with. The medication is not included in the bundle either. So again, you just use this in a situation where you need to tell the carrier that in this particular instance, I'm using these two procedures together appropriately. And there are times when people use the 59 when there's a better modifier, and we're told that if there's a better modifier, you should use the better modifier. And these have been around for a while. These are the X modifiers. Medicare says they want you to use them. Private insurance companies say they want you to use them. And when you use them more often than not, the claims end up being rejected and you end up resubmitting it with 59s. But at any rate, be aware of them. Eventually, they will become commonplace, but I think there's computer programming problems that have not got these to work the way they're supposed to. So an XC is a separate encounter. So this would be patient came in and they had plantar fasciitis, and you gave them a heel injection and they went home, and later that afternoon they tripped in their yard and broke their fifth metatarsal. They come back to the office and you see them for that. That's a separate, completely separate encounter that occurred at a different time. Separate structure, this would be a situation where, say, you injected a neuroma and plantar fascia, separate structures. Separate practitioner, this would be typically used if, for instance, you were in an orthopedic group and you had a patient that came in and you injected a neuroma, and your orthopedic partner on the same day saw that patient and aspirated their left knee. The lesser of those two procedures, which you'd have to look it up in the CCIs to see which it was, but probably it'd be the neuroma injection, would get the XP modifier. And then the XU modifier, just to be aware that it exists, is unusual non-overlapping services. And if you ask anybody exactly what that means, they're lying if they think they know, because no one seems to really understand exactly what the XU is. So these modifiers are also frequently used. Modifier 58 is a staged or related procedure by the same physician. So if you do a procedure that carries a 90-day global, which means that everything for the next 90 days related to that procedure is included, and then you do another procedure related to that at a follow-up visit, you would use a modifier 58. And again, an example of that, again, I'm mostly living in the wound care world, so I'm going to use that. If, for instance, I did a open amputation of the right great toe and saw that patient back subsequently and needed to debride some skin and subcuticular tissue from the surgical wound as it continued to heal and stagnate because the patient walked on it and dehissed their sutures and all the things that our diabetic patients do, you'd use a modifier 58 if you anticipated or planned that you would be doing those follow-up procedures. And that's more than a coding issue, I guess, is a documentation pearl. So if you do a procedure where you anticipate or think that it's somewhat likely or plausible even that you may be doing a follow-up procedure related to that, I would put in the end of my operative report or in my pre-op note that you plan to need to do serial debridement on the wound in the future, or if you did an open transmetatarsal amputation and plan to go back and do a flap closure or something of that nature, you would put in your plan that you intended to do that. So there is a question that popped up. So how does this apply to a callus distraction procedure with adjustment of the fixator in the office? So it's not a procedure that I do, so I would have to see the description of the CPT, but my gut instinct in this situation is that you could not use the modifier to get around this, because the callus distraction procedure has as a required component to make those adjustments to the fixator. So if you're talking about a routine adjustment where the patient comes in and you basically turn the knob on the distraction, so you're distracting at 0.5 millimeter or millimeter, whatever the current protocol is, then that's going to be included in your procedure, because that's part of the procedure, even though it doesn't happen on that day. However, if that same patient knocked a pin loose or something like that, and you had to fix that problem, then that would receive a modifier, but not the 58. That would receive a different modifier that we're going to talk about. But again, I'm pretty certain that for a callus distraction procedure, unless the code is just an osteotomy code, the actual distraction would be included in the procedure. So modifier 78 is for an unplanned return to the operating room by the same physician or other qualified health professional following the initial procedure. So if, for instance, you did a Austin bunionectomy, capital osteotomy with screw fixation, and the patient decided on post-op day 2 that they were going to go skydiving, and came down nice and hard on that and dislocated their osteotomy, and you took them back to the operating room to fix that, that would basically be the unplanned return to the operating room. You'd apply the appropriate code for whatever you needed to do to fixate that, and append a modifier 78 to indicate that it was related to the original procedure, but it was not planned. One thing important about 78 is that it requires the use of an operating or dedicated procedure room. So you cannot use 78 if you're able to take care of it in the office. So for instance, if you did a neuroma and the patient had a hematoma, not an uncommon complication, so you had to do an incision and drainage of that hematoma, that complication is part of your procedure. It's an anticipated complication, so to speak, and it's included in the payment for the original procedure, and you can't bill a separate procedure with a 78 unless you had to take them to the OR for some reason, and you'd have to justify why you did. You couldn't just do it so you got paid. So modifier 79 is an unrelated procedure by the same physician or other health care professional in the post-op period. So this would be a situation where, say, for instance, you did a simple 10-day procedure, like an incision drainage of an abscess, and on post-op day 2, the patient came in and was complaining of plantar fasciitis. We'll use that again, I guess. And you decide to give them a cortisone injection. You would put a 79 on your cortisone injection, saying that it wasn't related to the paronychia. I went backwards to this unplanned return to the operating room, the modifier 78, that would be the situation where the patient has an external fixator and they need to go back to the operating room and have it adjusted or fixed because it was shifting out of position. Something was wrong and not anticipated, where there wasn't a planned adjustment that was going to be occurring. Back in the day when I actually did external fixators, I had a patient who was drunk and took a bunch of screws out of the fixator, and we had to take them, put them back in. So you never know. Modifier 24, this is another very common modifier. This is a modifier that is used with evaluation and management. This is for an unrelated evaluation and management during the postoperative period. So, for instance, if you fixed a patient's ankle fracture and that would put that patient in a 90-day global, which means that the next 90 days, all care related to that ankle fracture is included in the surgical procedure. And then they came in and they had acute gout. And you evaluated that and you gave them some Colchris or what have you, and ordered some blood work and basically worked them up and treated them for gout. That would clearly not be related directly to the ankle fracture, even if it was in the operative ankle. You would then be able to bill your office visit at the appropriate level and append a modifier 24 that just tells the computer system that this is not related to my ankle fracture. Another modifier to use with evaluation and management, again, pretty common, modifier 25. This is probably one of the most overused and inappropriately used modifiers, so it's one that does fall onto CMS's radar somewhat, and that is used when you have a significant evaluation and management service on the same day a service as a procedure. So a classic example is almost any new patient. You can use 25 with the initial office evaluation and management code, and your procedure, especially clearly you can do it if your procedure was not the sole management that was provided. So for instance, somebody came in with plantar fasciitis, you'd never seen them before, you work them up, you give them a cortisone injection, and you give them a prescription for a non-steroidal anti-inflammatory, teach them some stretching exercises, discuss with them appropriate changes in their shoes, so on and so forth. You document that you did all of that. You clearly provided an evaluation and management system service that was separate from the cortisone injection, and you can put a modifier 25 on it. However, if that same patient came in, you had seen them previously 2 weeks ago for plantar fasciitis. They came in, they just got a cortisone injection and left. There's no way you could bill an E&M for that. Third scenario, same patient comes in, 2 weeks later after you gave, 2 days later after you gave them a cortisone injection, they're in a 10-day global, and they have a sprained ankle. You can evaluate and manage that ankle and put a 25 modifier on it to indicate that it's not related to the post-op period they're in. Some other common modifiers left and right. There's modifiers for all of the toes, but not metatarsals, unfortunately. This does complicate things when you have procedures on multiple metatarsals. 80 is for an assistant surgeon. Again, there's only certain procedures that you're allowed to bill for an assistant, but when you are, you bill the same procedure code as the primary code with an 80 under the assistant's NPI and provider number. 53 is a discontinued procedure, so the patient had a medical event during surgery. hopefully you don't have to use this code ever, but I actually had a colleague here locally not too awful long ago who was doing a IND and a transmetatarsal amputation on a very sick septic patient, and they coded during the procedure and passed away, so he never finished his procedure. So that'd be a 53. 54 is surgical care only. Surgical care is going to be, so if you do the procedure and then you're going to hand it off to someone else, this is not uncommonly done. Say, for instance, you do total ankle arthroplasties, and you're in an area where you're in a major city, there's rural suburbs. Somebody who doesn't do it sends you that patient. It's too far for them to follow for follow-ups. You've prearranged with the other doctor, they're going to follow up. You're going to bill your procedure with a 54. He's going to bill the procedure with the 55, and he'll take care of the post-op care and you take care of the surgery. Again, you can even be struck by an orca, and there's a code for that. So only initial encounters, though. There's probably not a follow-up encounter for that one. So the other concept that you need to understand is the correct coding initiative. And I know I'm running a little long here, but let's see if we can make it through this. So the CCI is essentially a list of codes published in 2 columns that are not payable together typically. And this is published on Medicare's website. It's an Excel spreadsheet that you can download, or you can get it in a PDF, but trust me, you want to get it in the spreadsheet. And this is an example of what a little segment of that code looks like. 11055, this is a pairing of calluses. And then this whole list of other codes, most of them I don't know. This particular one is debridement of eczematous skin. These 2 are trimming nails, 1 to 6 and 6 to 10. So all of the procedures in column 2 are included with this. So you can't typically bill this code with any of these codes. However, this code column here is telling you that you are allowed to use a modifier to get around this if indeed there's a legitimate reason to do so. So in this case, if you were going to trim 5 nails and debride these calluses, you would be allowed to do that as long as the rule in this case is that the callus has to be proximal to the distal interphalangeal joint to be separate from the nail procedure. So if these were submet calluses and these were toes, you're golden, and you could bill this with a 59 placed on the column 2 code, which would be the nail care. So really quickly putting this all together, if you have a patient who presents with an ankle fracture, you do an x-ray in the office, decide to take them to the operating room that same day, patient's admitted, you change the dressing on the 1st and 2nd days. Day 6, you end up having to readmit the patient for cellulitis, and then you manage them for a couple of days in the hospital. This is kind of how it would look. So your first day of service, you would bill a level 4 new patient visit, pretty complicated problem. 57 modifiers saying this is the decision for surgery was made, because the day of surgery and the day before surgery are included in your 90-day global. You take your x-rays, you get paid for your x-rays, take them to the operating room, you get paid to ORIF their fibula. And then you see them for those first 3 days in the hospital. It's included in the 90-day global, no payment for that. You admit them for the cellulitis, that's included in your procedure, no payment for that. Similar situation, you have a patient with diabetes, coronary artery disease. You take them to the operating room to debride a large, deep wound. You change the dressing on the 1st and 2nd days. You see them post-op day 6 and have to readmit them. Same situation for about 4 days. In this situation, your wound care debridement is you're going to have a level 5 visit because this is a much more medically complicated patient. You have a 25 modifier for the debridement because debridement is a minor is a minor procedure. In fact, I take that back. You wouldn't even need a 25 because these are now 0-day procedures, the debridement codes. At any rate, you take 3 views of their ankle. You debride the first 20 square centimeters. This is an add-on code, so there's no modifier for the add-on code. And then you get your evaluation to management for the post-op days. When you readmit them, that's a new patient hospital encounter. And then those follow-up encounters, all simple level 1s. So I appreciate everybody's attention. And I believe we're kind of out of time. I'm certainly happy to hang out. If anybody has any questions, I'd be happy to take them. Okay.
Well, Dr. Goggin, we'd like to thank you very much for your time and for this presentation.
Okay. I hope everybody enjoyed it.
Very informative. Everyone, thank you for attending. We look forward to seeing you in September. Have a good evening.